Hi guys, we're going to get started in the interest of time. My name is Vinay Kamplith. I'm faculty at the University of Pennsylvania.
I'm Joey Siano, also faculty at UPenn.
And I am Morgan Broccoli, and I'm faculty at Brigham.
We are here on behalf of the Global Emergency Medicine Literature Review, or GEMLR, to report on the top global EM articles of 2024. So we collectively have no disclosures to report. And by the end of the session, you should be able to understand the methods of GEMLR, identify the top scoring articles from this last year, and learn about the methods, results, and conclusions for each top scoring article. So GEMLR is actually in its 20th year of publication AEM, which is a big milestone. Our missions are to highlight and disseminate high-quality GEM research, illustrate best practices, stimulate additional research, and promote further professionalization in the discipline of global EM. We are a scoping review, not a systematic review or meta-analysis. This is an enormous coordinated effort that takes 70 members from across 12 countries, and this is a year-long effort. Our search initially begins with a PubMed search comprising emergency terms and global terms. We do this search in two tranches, one from the first 8 months of the year and the second tranche from the last 4 months of the year. We also hand search pertinent articles in high-yield journals such as the African Journal of Emergency Medicine, the Bulletin of the WHO, Lancet, and Pre-Hospital Disaster Medicine. Our methods then follow to do an initial screening of about tens of thousands of articles. We categorize these articles into 3 categories: emergency care and resource limited settings, disaster and humanitarian response, and emergency medicine development. And we also further categorize these studies as the type of methodology they have, either an original research, qualitative, quantitative, or mixed methods, or a review article. We subsequently score each article on certain criteria, including clarity, study design, ethics, importance to the field of global EM, and the likely impact on GEM practice. We also have a gray literature component. So a separate search is actually conducted through gray literature, or articles published through less formal communications such as news bulletins, practice guidelines, and other media. And these are the organizations that we hand search for the great literature. So without further ado, the top global EM articles from 2024. From the search part of our methodology, we actually searched 46,700 articles. We screened 551 articles, and we are still in the process of doing our final review, but annually it's about 35 articles. So our top scored systematic review article from 2024 was from Adal et al. This is titled Mortality of Traumatic Chest Injury and Its Predictors Across Sub-Saharan Africa, Systematic Review and Meta-Analysis 2024. So we as EM practitioners know that chest trauma carries significant morbidity and mortality globally. The research questions from Adal et al. Were to actually understand what the pooled mortality rate of traumatic chest injury was in sub-Saharan Africa, and to also understand what the pooled factors contributing to the mortality rate of chest injury across sub-Saharan Africa were. Its methods adhered to the PRISMA guidelines, and it included all published and unpublished reports of chest trauma mortality across sub-Saharan Africa. There was an English language restriction, but no date restriction. It included all age groups and also included pre-hospital and in-hospital studies. In-hospital included emergency units, ICUs, PICUs, and NICUs. The studies solely focused on intrathoracic injuries were excluded, such as cardiac injury, and the search string included terms for mortality, predictor, chest trauma, and sub-Saharan Africa. The study authors did do a quality assessment using the Newcastle-Ottawa scale, and their main outcome of interest was mortality from chest trauma. They calculated adjusted odds ratios to identify predictors. So 845 articles were initially screened, and 21 articles were included in the final review. All studies were observational, either cohort or cross-sectional, and most injuries in this group resulted from road traffic accidents, and blunt chest injury was the predominant mechanism. The pooled mortality rate across articles in sub-Saharan Africa was 9%, and this compares to the United States, which was 0.16% mortality, and the United Kingdom, which has 5 to 6% mortality. The studies included in the results here were highly heterogeneous, but no individual publication contributed to publication bias, so they were not removed from the meta-analysis. Factors that were associated with increased chest trauma mortality included age over 50, increased time to presentation, and other associated injuries or comorbidities. So the importance of this article is really to contribute to the literature on point prevalence of different conditions in global EM. It also helped to understand upstream causes of increased mortality from chest trauma, such as prevalence of road traffic accidents, poor out-of-hospital care, ambulance EMS networks, and the lack of equipped trauma centers with trauma-certified personnel, protocols, and equipment. We also commend this article for identifying subgroups that were at higher risk for mortality, and this allows some more targeted efforts to improve systems of care.
All right, so I am going to be presenting on the top scoring original research qualitative article. And interestingly, it's not really a qualitative article, it's more like a mixed methods article. But it is on advancing access to care and assessment of the pre-hospital system in Senegal. So as we all know in this room, Sub-Saharan Africa has a disproportionate amount of preventable deaths in general, but also specifically in the pre-hospital setting. Very few African countries have formal EMS systems in place, and those that do likely do not reach the entire population of that country. Obviously, they're frequently found in large cities. The aim of this study was to describe pre-hospital care in Senegal and suggest opportunities to improve access to pre-hospital care. As I alluded to, this was a mixed method study, which used a structured questionnaire, which actually formed most of the data collection that they did, as well as one single open answer question. And that question was, what would you like to see improved in your current system? They developed the structured questionnaire from existing resources. They did, and maybe this is a little bit of my bias coming into this study, but they used mostly older resources from 2012, including the WHO Program for Emergency and Essential Surgical Care tools and checklists. They did also use the WHO Emergency Care System Framework, which is more recent and up-to-date. They conducted a purposeful sampling of professionals who had experience in pre-hospital system development or emergency care in Senegal, and the survey ran from August to September 2019. For their results, they managed to conduct 14 interviews with physicians from 10 out of Senegal's 14 regions. They did not reach, they said that the 4 regions that they didn't reach were the most rural regions, which does make sense. And they extrapolated that those 4 very rural regions, if they weren't able to find someone to survey from that region, probably did not have an active EMS system. Only 2 regions had what the authors described as mature pre-hospital systems. This meant that they had a dispatch center, they had trained personnel staffing the ambulances, and the ambulances were equipped. These mature pre-hospital systems conducted both inter-facility transfers and transfers from the scene. The 2 mature systems were located in the main cities of Dakar and St. Louis. In Dakar, they had 13 equipped ambulances for a population of 3.7 million. And in St. Louis, they had 5 ambulances for a population of 1 million. If you want to compare that, I believe Boston, our population is around 650,000, and Boston EMS staffs about 27 ambulances. So, you know, they did have mature, developed pre-hospital systems, but maybe insufficient ambulances to take care of the entire population. That does mean that approximately 30% of Senegal's 16.2 million inhabitants do have access to a mature pre-hospital system. Interestingly, these systems did sometimes provide care and transport to people from neighboring regions. But the authors did note that ambulance transfer costs about $25 US, so that was a barrier for many people in accessing those services. The other 8 regions that were surveyed relied solely on the fire department, and they noted that the personnel had no healthcare-related training. What I found very interesting was all regions did have a toll-free emergency telephone number for the inhabitants to call. That number connects the caller either to the dispatch center for those 2 mature systems or to the fire department for the other 8 regions. The ambulances for interfacility transfers, whether in the mature regions or in they called them like basic or immature systems, were not equipped with any resources. They were often staffed by the doctors and nurses from that hospital. The ambulances were hospital-owned, located at the hospital, staffed by doctors and nurses, and if the patient that they were transferring needed oxygen, they would just take it, if it was available, from the hospital and bring it in the ambulance. Another thing I found interesting was that all regions used the local cell network for pre-arrival communication. There was no radio use on any of the ambulances. And the qualitative part of this study, some of the responses for how the respondents would like to improve their pre-hospital system included increasing the amount of equipment and supplies in the ambulances, increasing the number of staff, and increasing the number of vehicles. The authors' conclusions, they made a list of recommendations for how the pre-hospital system in Senegal could be improved. One of my favorite recommendations was to offer some sort of basic pre-hospital training for the fire service who are staffing these other 8 regions. They also talked about creating checklists, creating a formal communication system for the pre-hospital services and the hospital, and in general, just increasing awareness, making sure that the population knew how to access the system, and then reducing some of the barriers, including funding-related barriers.
I will be closing the talk with the last 2 top scoring articles for this cycle. The first one is a RCT coming out of Iran that is comparing different medication regimens for fracture-related pain. The authors start by just describing the issue that we all know about globally with pain control, with orthopedic injuries. The majority of fractures that we see globally are actually fractures that involve extremities, and the majority of those are actually closed fractures, with the long-time standard being opioid therapy. The main objective of this study was to look at 3 different options for pain control for closed fractures. One of them being IV ibuprofen, second one IV ibuprofen plus acetaminophen, and third one being IV morphine. This was a single center RCT at a large tertiary care trauma center in Iran. The patients aged from 15 through 60 that were included in the study, and as mentioned, they only looked at isolated extremity closed fractures. The 3 interventions were previously stated, and the primary outcome they were looking at were reduction in a visual analog scale pain score by 1 hour, although the authors did look at reduction in pain scores at 5 minutes, 15 minutes, 30 minutes, and 60 minutes after medication administration. For the results, out of about 400 trauma patients that were screened, 158 met inclusion criteria to be involved in the study, and they found that, as would be expected, the fastest pain reduction occurred after IV morphine administration. However, the most sustained pain reduction was after the combination regimen of IV ibuprofen plus acetaminophen. In conclusion, this highlights bread and butter NSAID and acetaminophen use for fracture-associated pain and suggests a potential combination multimodal pain regimen for fracture-associated pain. I'll be closing with our great literature this year, which came out of Partners in Health. This was a very large study that looked at the use of rapid COVID testing. As we all know, prior to vaccine development, when we were in the heart of the COVID pandemic, COVID testing was used a little bit differently than it is used now. Prior to vaccine development, it was used mostly to reduce virus transmission, used for quarantining, surveillance purposes, and also to aid in COVID-specific treatments. But now that we do have vaccines that exist for COVID, the role of testing, even in the US, has been a little bit more variable. And looking at LMICs, the role of testing is something that is not well understood, and the cost effectiveness of testing is not well understood. And so the authors, their goal was to explore the cost effectiveness of COVID rapid diagnostic testing in informing treatments for severe COVID illness in low middle income countries. The authors did this by looking specifically at severe COVID-like illnesses in over 100 LMICs. They used the WHO definition of severe COVID, which is listed right there. Most of these points are pretty self-explanatory to an ER practitioner. Patients who are severely hypoxic, who have acute respiratory distress, signs of sepsis, shock, or needing life-sustaining therapies such as intubation. So they all met inclusion criteria. The methods involved the use of a very complicated decision tree where they looked at 5 main testing options and the downstream costs associated with that. So the 5 options were, number 1, not testing at all the patients and just assuming that they had COVID and treating them as such. Number 2 was using a rapid test only. Number 3 was using a PCR test only. Number 4 was using a rapid, if positive, confirming with PCR. And number 5 was using the rapid, if negative, confirming with PCR. So they used these 5 different options for the decision tree. And how they estimated the cost effectiveness was by using cost associated with dailies prevented over a patient's lifetime, with consideration for different testing practices across different countries. The results are a bit nuanced. There's not a clear answer to the question, are they cost effective or not? And it's more related to the degree of resource limitation that is present across the LMICs, as well as the COVID prevalence locally. What they found is in sort of a United States high resource availability setting, or LMICs that are more wealthy or have less limitations to resources, that they are always cost effective, the use of these tests. But in more poor LMICs or more resource limited settings, it is less cost effective to use them in low COVID prevalence conditions. On the other hand, in a resource-limited setting with high prevalence, they do become more cost-effective, especially when influenza prevalence is also high, because the treatment algorithms are a little bit different for COVID versus influenza. In conclusion, use of these testing and the cost-effectiveness does vary depending on the context and resource limitation. With that, I would like to thank you for your presence and attention. I have some resources here and would encourage any of you to apply to be a reviewer if you are not already a part of GEMLR, and to share this with any colleagues, especially in LMICs, so they can be a part of the review. We would be happy to take any questions. Any questions or comments? Okay.
Great. Thank you.
Thank you for your time.